Good morning. It's so wonderful to be here today. And I know from the chat that everybody is waiting very anxiously to hear Dr. Liedtke speak. So I just have a couple of announcements and then we'll get on with that. If you did not attend the upper cervical chiropractic session, let me introduce myself to those who don't know me. My name is Anne Simnecki. I'm the secretary of the board of directors, a support group leader, and more importantly, a peer mentor. I talk to a lot of people who have the same condition I do, and it really brings me a lot of joy to be able to help other people. And I get helped by them because everybody has a different story and different knowledge. So before we begin, one important announcement is tomorrow at the end of the conference, you will be emailed a survey to evaluate the conference and give suggestions for future conferences. And as David Meyer said earlier, that's what helped us shape this conference. So if you please complete that survey as soon as you can. And as an incentive to complete it, there will be a lottery at the end for either an Amazon gift card or this wonderful book called Facial Pain, A 21st Century Guide. This is the latest book that the FPA has put out, and it's really a wonderful, wonderful book to have with you. So now I'd like to introduce the newest member of our medical advisory board, Dr. Wolfgang Liedtke, and he has just moved to Global Scientific Development Council at Regeneron Pharmaceuticals. He is the chair of neurology there. If you have any questions for Dr. Liedtke, please type them into the chat and I'll be keeping track of them and asking them at the end. And I would also like to, before we begin, say we are having a terrible blizzard on the East Coast. So from the Carolinas up to Maine, we're seeing very serious atmospheric lows. The atmospheric pressure here in New Jersey and New York has dropped 48 millibars in the past 24 hours. And that is very significant. And for those of us who are affected by atmospheric drops, you might be in more pain than usual today. But remember, if you are, you're not alone. You're here with your community, and that's what we're here for. And we'll support each other. Just take care of yourself through this conference. Take a break, do whatever you need to make yourself feel better. And with that said, Dr. Liedtke, I will turn it over to you.
Great. Thank you so much. Thank you for the kind introduction. And I was so appreciative of Claude and Jean sharing. That was just touching, and you could see the patient. I follow the patient journey as I have followed many over my years as a pain doctor, pain neurologist out of my former academic home at Duke University. So the blizzard is around us and is making trigeminal facial pain sufferers suffer more with this abrupt low in atmospheric pressure. So you can ask a question by the chat, don't have to speak. And also with my perennially optimistic nature, I've already put on a coat in honor of the Lunar New Year, which is coming up. So already looking past this bad weather and looking for the Lunar New Year coming up next week, the year of the tiger. All right, so I'll be talking about medications for facial pain, and I have moved out of academia and into the corporate world to try to help develop new medicines from that vista. And I was Regeneron. Regeneron says science to medicine. That's me. That's how I felt really attracted to that company. And that's what I have also been doing at Duke. And I did also join NYU College of Dentistry, the pain research group that is led by my friend Nigel Bunnett. So I'm speaking as an academic, and I'm not speaking officially on behalf of Regeneron here. That is just my affiliation. It's just who's on whose payroll I am currently, but I'm speaking here as myself. All right, I have been a clinically based investigator, laboratory-based investigator. That has perhaps and hopefully made my practice have me approach the subject, the problem that my patients brought to me from a unique angle. And as such, I have been doing things in the laboratory, trying to translate and reverse translate human disease into experimental models. For example, reverse translating TMJD, temporomandibular joint disorder, into the mouse, where we can measure and where we can use genetically altered mice, and focusing on molecules like TRP ion channels, which are not yet targets for anti-pain therapies. But I have also been treating patients for the last 17 years, until April 2021, with several thousand encounters in my 2 clinics in Duke Neurology and Duke Anesthesiology, meeting patients who produce masks like this in art therapy, and trying to help patients who have comorbidities that make them suffer more. So now I am a biotech pharma executive, but again, science to medicine, that's what my angle stands for. Medications for facial pain, let's get into it. And I decided to start with not with layout about regular medications that are to be taken regularly, but one slide here that I think every patient with facial pain should take to heart, and their doctors and their treating clinics. Is there a need for fast-acting medications that act on an as-needed base? And that is, of course, when there are attacks and when there is with a little bit slower kinetics, episodic worsening, so that the regular approaches need to be met with extra medication. And with that, I'm saying the earlier this extra medication is brought in, the better. If you can suppress the pain while it is ramping up, that's really, really helpful, and that's what you want to do. If the pain has established itself and sort of have put its ugly foot on the ground, then sometimes, retreat and go in a dark room and just like do what you do in that situation. That's the best you can do. But if you can hit back and you can fight back really early, that has a chance of being effective, and you need medications to be able to do that. One prerequisite is, of course, that this attack or episodic worsening is announcing itself. If it's coming out of the sky like a flash, and your latency is seconds or milliseconds, that's a little bit too fast. So there needs to be something that the patient knows, oh, pain might get worse. And if it might get worse, you are allowed to shoot into the sky and shoot a blank. That is better than suffer a pain attack because you were too cautious with your medication. So what can be used for these purposes? We can use sodium channel blocking antineuralgics, chewable carbamazepine, liquid oxcarbazepine, as the name says, they are related medicines. This comes as liquid, this comes as chewable, so suitable for that. Gabapentin also comes as a liquid, can be used for that purpose. Perhaps this has more punch acutely and works perhaps faster because it blocks the sodium channel. This is sort of like perhaps slower acting, but then some patients might be better with liquid gabapentin than with liquid oxcarbazepine. GABA A receptor binding benzodiazepine, that is, clinically speaking, that's clonazepam, because clonazepam has the highest activity against trigeminal pain of this entire group, where diazepam is perhaps the most famous one. There is also lorazepam, which is particularly good with anxiety. And that can be good with attacks that are really hitting hard in terms of emotional suffering. Orally dissolving gepant medication is much newer. These are all older medication. Orally dissolving gepant medication, that is borrowing from the world of migraine. Rimegepant can be used orally dissolving at 75 milligram. And so here we are trying to repurpose a new medicine that is borrowed from the world of migraine, but it inhibits so-called CGRP. And CGRP is not only a pro-pain principle happening in migraine. So it goes through the tongue, and with that there is fast onset. It might very well be suitable. Since it's so new, it will deserve its spot for a clinical study to assess the effects in a more controlled manner. From initial experience, I'd say it might very well be useful and is a good thing to have, perhaps a little bit less well established than the above three. So nasal sprays of, there are G-Pan nasal sprays of this Remit G-Pan. That's why it's the G-Pans that knock you out of your pants. So the Rimegepant is through the tongue. Nasal spray of G-Pan medications are coming. So it might be acting even more faster. Nasal spray acts on the second branch of the trigeminal nerve. Orally dissolving acts directly onto the third branch of the trigeminal nerve, a little bit on the second. So that might also be taken into account when you do as needed medication against attacks. Big nasal spray, okay. Ketamine nasal spray. I have prescribed a lot of ketamine nasal spray. I think it's a great medication. Problem with it is the form that is an off-the-shelf medication, that is Spravato, has been FDA approved for therapy refractory depression. So really severe psychiatric disease, life-threatening psychiatric disease, is quite expensive. It's very restricted in its use. So for trigeminal pain, for facial pain patient to get Spravato prescribed is prescribed and covered by insurance is not likely, or in my practice has never happened. So I had the practice of prescribing ketamine nasal spray as a compounding medication at a dose of 10 to 15 milligram per squirt. So one squirt is 0.1 milliliter, so it's 100 to 150 milligram per milliliter. And we used to prescribe it at a tenth of this because we were sort of afraid of ketamine. And then rarely that ever worked. But if you use 10x, 100 to 150 milligram, it has quite a great record. It's perhaps one of the most fast-acting agents against trigeminal pain flares. Nasal spray, I also want to mention oxytocin nasal spray is probably less potent than these, but it's super harmless, and it might also be a good addition to other therapies on an ongoing basis. So I would also recommend oxytocin nasal spray to consider for this purpose. It's also compounding. It's not made by any major company to be off the shelf. I would also want to see something that patients with facial pain that have attacks and periodic worsening can use to fight an upshoot of their blood pressure, because blood pressure shooting up during the attack is something that's not good. It will make the pain worse, and we should have medications that can target this. So Verapamil as a 40 milligram tablet can be prescribed and is pretty fast acting. However, it would take 20-30 minutes to start acting. And that's better than nothing, but we would rather have something like either a nasal spray or orally dissolving medication that lowers blood pressure, of which there is currently that cannot be prescribed as far as I'm aware. One can use orally dissolving clonopin, liquid lorazepam, to bring down the anxiety level, and indirectly that will also help with the blood pressure. Okay, we come to regular medications now, and that has several chapters. So here's the first chapter. Regular medication, tablet taken by mouth in regular intervals. Sodium channel inhibiting medication that have entered the textbooks of medicine, carbamazepine, oxcarbazepine. The latest eslicarbazepine with the typical doses here. There's regular medication, extended release formulations. Whatever works better for the patient to bring down disease activity is to be prescribed. It has a relatively narrow window of it being helpful and then reaching levels where it's not helpful anymore and has side effects. Carbazepine is a bit more new and has a mechanism of action beyond sodium channels, might also do something to some other molecular targets and therefore be more suitable. So it's perhaps a little bit of an advance over these older ones. But here in purple, my favorite lacosamide is Vimpat. Lacosamide Vimpat, 100 to 200 milligram twice a day. The most potent sodium channel blocking medication that can be prescribed at this point, and has a better window of helping and side effect. That type of window is more is favorable for lacosamide versus these older drugs. I have helped a lot of people prescribing Vimpat. Sometimes it's a battle with the insurance. Sometimes you have to petition the maker, UCB Pharma, to supply it to the patient for free, which typically they do. And then sometimes Vimpat at higher dose can make a patient have obsessive thinking, and obsessive thinking of really bad thoughts that has led patients to become very exasperated. So I don't remember a single case where we had to completely drop it. And what could be done is, after pausing the Vimpat, then using a lower dose and slowly get back in, and then supplementing it with these. That has been the way out when this obsessive thinking side effect occurred, which is fortunately rare, but if it occurs, it's concerning. Here's a less potent medication, zonisamide, but it can also help a lot of people. Zonisamide mentioned here because it might have a favorable effect on control of body weight, which is also an issue with facial pain. So zonisamide will not increase a patient's body weight. It might help decrease, even though it's not that potent in that department either. So lacosamide, zonisamide are suitable when sodium goes down. In sodium going down with these three, that's a real problem because you're trying to fight trigeminal pain. It helps a bit, you go higher. Sodium goes down and the drug will not work anymore and the pain will get worse. It's really, really a big problem of this syndrome of inappropriate ADH secretion, the SIADH, that lowers sodium in the body, is elicited by these sodium channel blocking drugs. It's a brain, that's a side effect from the side of the brain. Gabapentin, pregabalin, mainstays of trigeminal nerve pain, both neuralgic and neuropathic. Versus sodium channel blocker, more toward the neuralgic variant, but also helping patients with neuropathic pain. Gabapentinoids helping both sides of the aisle. At this dose, can be dosed higher when you are slowly dosed in. Then you sometimes have to fight the side effects of like sedation and brain fog. Pregabalin side effect can be weight gain, and that has to be taken into account and can also be successfully fought if this is a helpful medication. Careful dosing can be done with also with liquids and with small tablets to be added. This is available as small as 100 milligram. Pregabalin is available as really small tablet, 50 milligram. I think even 25 milligram can be used. I also mentioned here lamotrigine, very nice medication, very helpful. The only problem is you need a slow dosing in, so it will take about a month and even a bit longer to get to the final dose. Otherwise, lamotrigine can also be a very helpful medication. Regular meds 2, SSRI as NRI means serotonin reuptake inhibitor, selective serotonin reuptake inhibitor, selective noradrenaline reuptake inhibitor. So neurotransmitter, neural messenger molecules are being not brought back into the neurons and act more. So more serotonin, more noradrenaline was thought to be an antidepressant. So this is a follow-up medication for Prozac. But then it was found it's not bad for mood, but it's even much better for pain. So Cymbalta is a great pain medication. Combination with gabapentinoids, that's great. That's a default pathway for a more severe nerve pain and has helped many patients. I would combine them, definitely. But can also be meaningfully combined with the sodium channel inhibitors. Sometimes this leads to, this cannot be tolerated by patients through some type of a serotonin syndrome, flavor thereof. In a funny way, venlafaxine can be used in those instances and has helped many people when duloxetine was not tolerated. Also, the capsule here is at 20 milligram content, the lowest dose. I have had some patient who cut the capsule with a scalpel and then go to these mini capsules inside the big capsule to get to when they felt they can't tolerate 20, but they know it helps. And then they were able to work with these mini capsules. But venlafaxine doesn't have that capsule. In the capsule, you can use half of 25 milligram, or you can formulate it in a compound in pharmacy for a lower dose if needed. And what I'm saying here is go all the way with these SSRI as NRIs, even if the first attempt might be besieged by side effects or it's too strong, or try to orient yourself and look for the alternative like vortioxetine or recently added medication, sometimes more punch than duloxetine. Mirtazapine normalizes sleep and has a little bit of different flavor versus the other. However, mirtazapine is used, for example, in patients with a problem maintaining weight to help them gain weight. And that, of course, in the treatment of chronic pain can become a problem, can enhance weight gain. So milnacipran is like a Cymbalta duloxetine 2.0 when there is comorbid fibromyalgia. And in that case, milnacipran can be a nice step up. Likewise, I would say not only fibromyalgia, but also other autoimmune disease as comorbid. And we will come to that. So that's SSRI as NRI, big chapter or big box. Cannabinoids, there is medical marijuana and natural products, but here is Marinol as a prescription medicine, can be prescribed. Sometimes difficult to get through insurance, but nausea and cachexia, or nausea and difficulty maintaining weight can be used as arguments that are typically taken by insurers in the context of facial pain. Here's the doses, 2.5 to 20 milligram, 2 to 3 times a day, so big window. And I haven't seen a patient for whom this was a decisive medication. However, a helpful second, third, or fourth line agent it has been for some, and in that case has been making the entire set of a more well-rounded approach. So I do want to mention it and list it here. And perhaps with interest in the cannabinoid signaling from the side of science, there will be more than just Marinol, which is, after all, is good to have it, but is also an imperfect product. That influences a form of neural inflammation also by acting on these cannabinoid receptors. And here we are with anti-inflammatories, which are essentially derivatives of good old aspirin. So here I'm mentioning indomethacin, one of the strongest, also good old, it's like decades old medicine. With this dose, it's very potent. It inhibits COX-1, COX-2, so it's not selective, and it can give patient nasty stomach problems, colitis, stomach. Long-term use can damage the kidneys, so long-term use is problematic, but it is very potent, and if it's very strikingly effective, then it's almost diagnostic of the presence of a paroxysmal hemicrania disorder that can mimic trigeminal neuralgia. Other than that, if there is something inflammatory and the doctor really wants to wipe it out, that's a good thing to try. Acts very fast, so within a week you know. For longer term use, where inflammatory comorbidity has to be fought, meloxicam is less a COX-1 inhibitor, more a COX-2 inhibitor. So that means the stomach and the colon will be spared. And it's a once a day medication, so it's not working as an acute anti-pain medication. Indomethacin does, meloxicam does not. All right, number 3, 2 of my favorites here. Low-dose naltrexone is a unique medication, a unique treatment approach for treatment/prevention. And I say in combination with a well-balanced standard regimen. Superb safety profile. That means what is happening with low-dose naltrexone is the same what you get with a placebo. So that means to me it's safe. In my hands has changed many lives, many in capital and in bold. That's my record. I have not yet managed to write this up so that other doctors can read about it. But this is my bottom line here with my experience low-dose naltrexone. It goes once a day. You start with 1 milligram, then you give 2 milligram, then you give the final dose of 4.5 milligram in intervals of 2 weeks or 4 weeks increase. Sometimes can also go up to 6 milligram when 4.5 milligram looks good, and then feeling okay, maybe a little more. But overall, low-dose naltrexone does not follow a strict dose-response regimen, and target dose for most patients is between 2 and 4.5 milligram. Better take it before bed, because there appears to be something, how this medicine works, mechanism of action, MOA, how it works with the circadian rhythm. First mechanism of action, number 1, kick on endogenous opioid system, because naltrexone is an opioid blocker. Given at low dose, it's not the standard type of opioid blocker that you would use to counteracting opioid overdose, or use high dose naltrexone in addiction disorders, where you give it for people to not have cravings or not give in to cravings. Then you use high dose naltrexone and related medicine at high dose. Low dose is a totally different chapter and can of worms, and it will a little bit block endogenous opioids, and then before sleep, that will lead, when the medicine stops acting because it's so low dose, there will be a rebound. And if we go from wake to sleep, the rebound is more powerful than what you get if you do it during wake, and during sleep you can't do it. So if you do it during wakefulness, it's working okay. But if you time it right with the circadian rhythm, it can be a nice large overshoot, and then the endogenous opioids will hit the brain when the patient or when whoever takes low dose naltrexone starts sleeping, and it could be extraordinarily good. Number two is if it appears to have an effect on glial cells. And glial cells are not nerve cells. There's glia, means glue in Old Greek. And so they are considered support cells, but they are way more than just support. They're pretty sophisticated players. And they can also become very nasty, and they can assume a leading role in chronic pain. And so this is, to my knowledge, one of the very few, perhaps the only medication with a so-called gliotropic effect acts on glial cells, also in synchrony with the circadian rhythm. And these 1 and 2 mechanism of action might be stuck together, might not be independent. No company makes it, has to be prescribed as a compounding medication. It's not a controlled substance, and it's not an opioid. It's an opioid blocker written at low dose. So to get away with the confusion, it's not an opioid, not a controlled substance, but it has to be compounded. Ultra low dose naltrexone, for those who do not tolerate this regular dose, that raises the question of comorbidity, but it also means don't give up on it if this lower dose for some reason cannot be tolerated. And mostly it's gastrointestinal and sleeplessness that I have heard of. But if that happens, I would go on the hunt for a comorbidity in the field of autoimmunity, fibromyalgia, where I have not seen this happening outside these comorbidities with relatively serious manifestation. So my suggestion, or what one could consider, is low-dose naltrexone after an invasive fix for trigeminal pain, like microvalvular decompression, or when the stereotactic radiosurgery has been conducted, when patients typically get better or get really good. But then if we look at a certain cohort of these patients, like 100 patients that received MVD or 100 patients received gamma knife, get better, well, we look 2 years later, we look 5 years later, a certain percentage of them will have undergone a relapse of the pain, perhaps not to the major form, but pain has come back. And of course, as doctors, we want to lower the percentage of that and bring it towards zero, so that the MVD lasts 5 years, 10 years, or forever. So low-dose naltrexone, could that be our bridge toward that? But that would definitely have to be clinically trialed. I don't think that, for example, me in my former Duke practice, where I prescribed things and I observed them, you need higher numbers, and this needs to be done in a concerted manner. But I think, as a suggestion, it occurred to me, given how effective and how safe this medication is. I also want to mention here the nasal sprays with oxytocin and with ketamine that can become a regular mainstay of medication with daily use. And then with both, one can consider use in a form of do it 5 days per week, and for 2 days a week you pause to make sure that this system, the ketamine system and oxytocin receptor system, regenerate, and that it will not lose its grip. It will not lose its effectiveness. But nasal spray with oxytocin, ketamine, both compounding medications, can be considered as a regular management strategy with a nice safety profile, I have to say. All right. Regular medicine number 4 has to be mentioned because we now have anti-CGRP medications, and that is for subcutaneous self-injections, and we borrow from the field of migraine. So these are self-injected anti-CGRP monoclonal antibodies made by Lilly, Teva, and Amgen at these doses. And these are the doses that chronic migraineurs get prescribed from their doctors. Once a month, they self-inject. So my thought is that perhaps a higher dose might be helpful, or that might be the real deal for facial pain, both neuropathic and neuralgic. Given that we know that galcanezumab from Lilly is used for cluster headache with effective treatment, and it's another horrible form of pain, where 300 milligram is needed for cluster versus, and not the 120 that is used for migraine. So for cluster, you need more, and therefore I'm thinking, well, for pain like trigeminal neuralgia or serious severe neuropathic pain of the trigeminal nerve, this should be upgraded to the cluster dose. In the future, as an outlook, these hypodermic needles and patients sticking themselves with pens, etc., it might be replaced with so-called microneedle patches, which look like which look like Band-Aid, but they have tiny, tiny, tiny needle that goes through the skin and then deliver the fluid once they make it past the skin. Half an hour later or an hour later, the patient pulls it off and the drug is in the system, so no more needles stick. And also then no more doctor, or you can get that mailed to your house. All right, number 5 has to be mentioned here explicitly, opioids. What's the role for opioids in the management of trigeminal nerve pain? Well, many patients are on low-potency opioids, and I mean hydrocodone, oxycodone, tramadol. And here is my wisdom after 17 years of practice. If helpful, in bold, can be used under appropriate guiding principles. And if helpful, that means it's honestly, yeah, it makes life better. And the side effect profile and the disadvantages of using an opioid are outweighed by the effect it has on quality of life. So I know a lot of patients with chronic facial pain in whom these medicines given at low dose and prescribed over years mean the difference between ability to function in the job and socially and as a human being, versus if these medicines are not around, they are not, patients are miserable and have a much worse quality of life. And in that respect, I'm saying, well, if we know that and that works with the patient life, let's keep the management and see how can we make the management better. However, one aspect here, if helpful in bold, yeah, it needs to help, right? And that needs to outweigh the bad side. When taking low-potency opioid, the door is shut to treatment with low-dose naltrexone, and that's a real valuable asset that's worth fighting for. So if low-dose naltrexone could be brought in, that could change the entire ballgame. It can make life completely different, and is worth fighting for, to see that these opioids, if marginally helpful, and it's not that big of a deal, can it be weaned off and then instead bring in low-dose naltrexone? And then once low-dose naltrexone kicks in, which could take a while, months, that could change the ballgame, in a transformative manner. All right. So low-dose naltrexone, really, that is a very, very valuable principle, and it's worth fighting for by getting rid of low-potency opioids. When using low-potency opioids, aim for drug holidays so that these receptor systems, these opioid receptors, do not desensitize, so that the susceptibility to these medicines maintains susceptibility. Long-term use is also calling for so-called opioid rotation, which means you would flip hydrocodone against tramadol, or you would rotate them against one another. They are opioids, they act on these receptors, opioid receptors, but they don't do that in the exact same manner. And therefore, this opioid rotation, as I heard about by a colleague from Memorial Sloan Cancer here in New York City, the late Gavril Pasternak, Dr. Pasternak, so the cancer pain Pasternak, not Michael Pasternak of the Facial Pain Association. So Gavril Pasternak made a clear case for opioid rotation in cancer pain. And I discussed with him and say, hey, if these patients with trigeminal pain, if they need it and they use it over years, how about that? And he said, well, you do it likewise. So I did learn this from my late colleague, Gavril Pasternak, that opioid rotation can be very helpful. And if it's practiced long-term, that's what you want to do. Across the board, phobia, and I mean phobia on the side of the clinics, the doctors, the providers, that they say no, and don't even come here, don't even give me a phone call over that. Across the board, for combined treatment of those low potency opioids with, for example, orally dissolving Klonopin, to me is not justified, because this orally dissolving Klonopin is given in these doses of an 1/8 or a 1/4 milligram, and even if you have that 3 or 4 a day, that is not a significant dosage to apply this like an ironclad law. Yeah. So in case low potency opioids appear essential and long-term treatment will be needed, but there is still significant pain. So we have opioid responsiveness, but it's partial opioid responsiveness. And these are low potency opioids, and you could throw in enormous amounts, but you could also consider longer term management with methadone. And methadone is a great medication to my estimate, because there are tablets of 5 and 10 milligram that can be cut in half, And there's also liquid. There's a liquid methadone so that one can do low dose methadone or ultra low dose methadone or odd doses like 7 milligram times 2. You can do that with liquid. You cannot do that with those tablets. Methadone, inexpensive, available in, for example, in any corner of the United States. You can get methadone to any remote pharmacy. So that's great about it. Butorphanol is slightly favored by official channels, I'd say. I'm not sure which of those is better. Butorphanol is very helpful in longer term management when opioids are indeed needed. Perhaps I was more familiar. I had more feel for how methadone goes. Of those three, I favor the last one, levorphanol, which is an even older medication than methadone, which is of 1963. So it looks like we need something new. Levorphanol, even older, but still a little bit better, has a little bit the edge over methadone. Pharmacologically, in terms of how these drugs work, methadone is not just an opioid. It also has actions on some other neural systems like so-called NMDA receptors, which is good, which is a good anti-pain strategy. That's also true for levorphanol, which has an overall better safety profile, where, for example, methadone also influences the immune system and wound healing, whereas levorphanol doesn't do that. Also mentioned here, fentanyl patches. Opioid rotation needs to be brought in to maintain that this still works, because otherwise the danger of losing effectiveness with fentanyl patches is quite high. I also mentioned fentanyl lozenges here for as needed palliation. I think it deserves to be mentioned, especially in the context when true pain palliation is needed. This is available, and doctors and clinics should not forget about that. However, this is sort of an extreme measure.
Dr.
Okay,
Liedtke,
so yeah.
We are coming close to the end of this presentation, and it's so interesting that I think we're going to invite you back to do a few more. But I have some really interesting questions right now, if you would entertain them.
Okay, let me one, two, I think 3 more slides and I'm through. Perhaps we can just finish and then have the questions.
Okay.
Yeah. All right. So opioid, future of opioid. I had the honor of working with a group in China, and we found a medicine that acts on opioid receptors pretty much without the disadvantages. And this Chinese group from Lanzhou University is not the only one in the world working on that. So there will be opioids 2.0, 2.0 and 3.0. Stay tuned. And it's not a good idea to have this dogmatic attitude and say, oh, opioids are just from hell, and therefore let's not even think about it. All right. Vigorously fight comorbidities, as shown here with the mixed martial art fighter fighting the comorbidities of these topics need to be brought to attention by the treating team. And doctors and clinics and helpers, providers need to be on board who understand that these comorbidities contribute to the pain. And to say, oh, I'm a specialist for hypertension, let me do my job, but with your pain, go to the pain specialist. There needs to be a transdisciplinary outlook and perspective. We treat the patient, the entire patient, also their social environment, their family, blah, blah, blah. But we treat the patient and we don't treat the hypertension. We treat the patient because the hypertension makes the neuralgia worse. Fibromyalgia makes the neuralgia worse. Same trigeminal system. Bad sleep is super bad. Brain fog, no good. Other pains in this trigeminal territory, super bad. Multiple sclerosis inflames the brain and the brainstem. Chronic inflammation in the body, probably long COVID part of that. It needs to be attacked like this. Sinus disease, we heard about it in the first talk. Go after it. Obesity needs to be fought. And they say, oh, diet and eat less. Well, we have now semaglutide that has a record of 15% lowering of body weight, and there is more coming. So obesity needs to be fought. Low-dose naltrexone is weighing in on that on the right side of the scale. Dental issues, dentistry-related issues have to be taken into account, as have ENT disease, eye disease, malignancies of head, neck, and also skin diseases. And the closer they get to the trigeminal nerve, the more meaning they have. All right, I have fixed these comorbidities over the years in my Duke clinics and become quite quite apt at that, and that no reason why other doctors and clinics cannot do that as well. All right, intravenous, we have lidocaine, phenytoin, which needs EKG monitoring, and which is for urgent care and infusion centers, but also underused is the corticosteroid of methylprednisolone, 0.5 gram to 1 gram, 3 days in a row, up to 5 days in a row, can be repeated monthly for about half a year, and then can be done every 6 to 8 weeks, can be tremendously effective with trigeminal pain because it's a wipeout against inflammation and also has direct effect on the trigeminal pain system. This is the only anti-inflammatory we can infuse meloxicam. There's no aspirin intravenous in the United States, unfortunately, so we can do meloxicam. And we can also do this CGRP medicine. That is the CGRP blocker for intravenous use as a monoclonal antibody. So borrowing from the world of migraine and blocking CGRP, which is neurogenic inflammation. New, attractive for urgent care emergency room use, perhaps also for interval use to improve pain control when other things don't work, and see whether this intravenous has an edge over subcutaneous. Needs to be trialed out in clinical trials. Okay, care teams are needed. Nobody owns this form of pain. We did research at Duke. I'm very proud of that. Hasn't been translated into the clinics. It would mean DRESS is done here, invasive method we hear more about. Our research means there's another location that might be way more attractive to target with a DRESS to fight trigeminal nerve pain because of this new pain superhighway that we discovered here. All right, yeah, well, that's it. Never give in. I put a playlist for people to enjoy, some upbeat music that was playing around at the time when I studied medicine. So, and I say, be of that mindset. And I say, you're not alone. And with that, we take questions.
Okay, well, we only have time for a few. So I'm going to ask you 2 questions that, to start with, that really focus on quality of life. So the first one is, can you start a family when you're taking any of these drugs?
Taking the drug and starting a family is compatible.
Okay.
I don't want to say across the board, like you have to or you will always be in a position. So that it depends. But as a general bottom line, I'd say if the facial pain is managed and there is ongoing management, and is that compatible with the starting of a family, I'd say overall yes.
Okay. So you can take the drugs while you're pregnant.
Management of a woman being pregnant and then managing trigeminal neuralgia is feasible, yes. And there are there are data on what these drugs actually do during pregnancies. And there's some baddies that need to be avoided, and there's others that have certain type of low risk to them. And I just bring up an example where a trigeminal. I have followed multiple pregnant women through their pregnancies with facial pain, and one comes to my mind who needed a relatively higher amount of opioids. And then people were getting cold feet, and I was on the phone with the obstetricians a lot, but she came through it, and I made an argument that sometimes there are women on opioids and that are not opioids that are prescribed by doctors, and they give birth to children, and that has been managed as well with not much fanfare. So why don't you bring your wisdom from that corner? And I think that brought a spark to their imagination, and then pregnancy and birthwise, despite these opioid amounts that made many doctors lose their pants, it went well.
Okay. And I have a related question. Several people have noted that these drugs inhibit libido. And is there any drug that would fight neurological pain that does not do that?
So sexual, if interference with normal sexual function from these drugs can happen. And then, for example, carbamazepine can be bad. Gabapentin Lyrica can be bad. Marinol is a strong THC. It's THC can be bad. Effects vary and can also be managed. For example, I remember a patient. He was helped by both OxyContin and hydrocodone. That was quite important for him to have. However, he used the oxycodone sparingly because the oxycodone interfered with his sexual potency. The hydrocodone did not. So with hydrocodone, that was fine, and he managed well. He put oxycodone into the mix, and it wasn't.
Okay, and do you have any advice about titrating off of these drugs if you need to get off of them for some reason? Or if you want to switch from one drug to another?
Yeah, well, titrating off, if you can titrate off, that's great. Sometimes you need to make relatively abrupt switches, and that needs to be managed in like you make the abrupt switch and stay in close contact with the clinics. That is sort of like you switch carbamazepine against oxcarbazepine. Mm-hmm. But then if you have low sodium, well, that's not a good situation to be in, because the sodium needs to go up, and with that's not so easy to treat. It's just you cannot eat more salty food. That won't fix it. So you will need to essentially bring down your carbamazepine and then come in with, for example, Vimpat zonisamide, or with another combination that would buffer and rescue you. Mm-hmm. And so those are relatively abrupt changes that then happen. So again, I think it depends a little bit on the clinical context, where you have to be abrupt when the circumstance dictate, and then the abrupt has to be replaced, because otherwise you stand in the rain with no coverage against that pain. And if the circumstance allow, wean off, wean in, and be safer.
Okay. Well, I cannot thank you enough for this presentation. There's such positive feedback in the chat. And I want to remind everybody that these presentations are being recorded so that you can see them again if you want to. And we are definitely going to invite you back to do more, because
so we can do updates on this as well. What we will learn about this CGRP business and the migraine drugs and what is coming. Is ketamine nasal spray somebody making that from a corporate standpoint? and maybe Spravato becomes democratized and across the board. And I will also take a look at the line of questioning here, trying to answer some of those back and see that we.
Great. Well, thank you so much. It's just wonderful to have you on the Medical Advisory Board and to listen to your talks. Thank you.
Okay. Thank you very much. And everybody be.
Not sure if I can do that.
All right.
Not. Maybe with this hand. Okay. Bye-bye, everyone.
Bye-bye.
Thank you.